Thank you. I would first like to take this opportunity to thank Dr. Nadia Yusuf, who's been my mentor, a very close colleague, and someone who I have kind of worked with for a significant period of time. Absolutely amazing to have her here today to be able to talk to us on a topic that's very close to my heart, which is the use of point-of-care ultrasound in the acutely deteriorating neonate. So for those of you who don't know Nadia, Nadia is a consultant who works in Paris University hospitals. She is, I would say, the mother of point-of-care ultrasound in lung, and has trained me and has trained virtually the entire faculty who's been teaching on our course. She's also a simulation instructor. She is and has published hugely in the world of POCUS and neonatal simulation, and has a huge interest in quality improvement. So I'm going to ask Nadia to share her screen while I do the police work.
Thank you, Alok. I will share my screen and you just let me know when, we start. It should be loading.
Yeah, loading, visible.
Perfect. So just stay put for now.
We have a few more minutes. While we're at it, folks, I'm just launching a poll just for everybody to have a look at, to kind of see how many of you are currently using POCUS in neonatal collapse. I'm getting a few replies. Can everybody see the poll?
Yes, we can.
Yes.
Nadia, you can make a start.
Thank you very much, Alok. And thank you for the kind introduction. Thank you for making part of this. It's always a pleasure. And thank you to all of you who are logging in today. I know most of you, I think, now online, but I think many are new to our webinars. So going back to what Alok said, using point of care ultrasounds in emergency situations, in undifferentiated shock, is something that we're only starting to do in neonatology as compared to adult medicine, even pediatric intensive care, I would say. And I would really like to say that I totally agree with Alok. I think this is possibly one of the things that can change our management of patients give us a vision to, until now, we have been colorblind. We're using our clinical assessment, but sometimes when we're in the situation where we have previously stable infant who suddenly starts to deteriorate, we are, I think, in one of the most stressful situations we can be as neonatologists. It's very easy if we find, you know, the reason for this collapse. Is it, I don't know, some technical issues, ventilator problems? This is something that's quite easy to handle, and we're quite relieved. But being faced with a situation of undifferentiated shock or collapse is difficult, and we don't really have that many tools at the bedside. So for me, this is a big step forward towards patient-centered care and patient-centered POCUS protocols in life-threatening situations. I have no conflict of interest relevant to this talk to disclose. Lung ultrasound is a point-of-care ultrasound technique that's widely used in adult emergency medicine and in critical care settings. And there is a very high quality of evidence for its use in life-threatening situations. There's been a long lag time for its use in pediatrics and neonatology, but especially in neonatology, we've seen an exponential growth in the past years, and it is slowly transforming our clinical practice. So the using lung ultrasound as a technique for me is safe. We've seen a rapid growth, especially I'd say the last 5 years, although all in all, its use is quite limited compared to, I mean, the number of neonatologists and the number of infants, sick infants born every year. There is a high interest. So far, what we've seen in the literature is validation of some adult data, but we've also been able to adapt the use of lung ultrasound to our specific needs. So specific applications for specific neonatal respiratory diseases. And I think there is a huge potential for its use from the delivery suite to the NICU for retrieval and transport and much more. And what we do know is that lung ultrasound compared to chest x-rays, which is what most of us are using as our gold standard, well, we do know that it is at least superior in performance to chest x-rays. We have international recommendations that came out in 2012. So these were adult recommendations recommending that we should use lung ultrasound for diagnosis and management of pneumothorax, acute respiratory distress, interstitial syndrome, and consolidation. At that time, although there weren't that many papers out, there was still a chapter dedicated to pediatrics and neonatology. And since then, we have had the first pediatric-specific guidelines published in 2020 by the ESPNIC, with different chapters on point-of-care ultrasound for the critically ill newborn and child. And one of these chapters is lung ultrasound. These 11 points recommend its use in different situations, and the indications that we're using lung ultrasound for today are for diagnosis of pneumothorax, pleural effusion, specific neonatal diseases such as RDS, PTN, and meconium aspiration. And then, as in adult medicine, we're recognizing non-aerated lungs, such lung in atelectasis and consolidation, making diagnosis of pneumonia. It's a huge body of evidence in pediatrics on that. We're using it to evaluate lung aeration, lung edema, and so forth. I'm going back to pneumothorax because pneumothorax can be a life-threatening situation. Pneumothorax is often associated with a severely decompensating infant, or if we're talking about the delivery suite, a baby that does not respond to normal resuscitation measures. And we do know that in the newborn period, this is the period in life where we have the most pneumothoraces. The specific pattern to pneumothorax when using lung ultrasound is that we will have two different patterns on the same screen when we have all the signs. Basically, because ultrasound beams cannot go through air, we will not be able to see the usual normal signs of lung sliding, which we do see when there is, let's say, if you can see the right side of my screen, Here we've got one rib with acoustic shadowing in this cartoon, another rib with acoustic shadowing, and we have this brighter line, which is the pleural line. On the side where there is no air, what we will see, and I will show you here on the screen, this corresponds to the left side of this clip. We see there is lung sliding, meaning this back and forth movement with breathing, which is normal, and absent lung sliding is never ever normal. And what we will then see, if we're in an area with air between the two pleural leaflets, so pneumothorax, is that we will no longer see this back and forth movement. As you can see here on the right side, this part is completely still. And what we see are these parallel horizontal lines that are a reflection of this pleural line, what we call A lines. We don't see anything else, which we see here on the left hand of the screen. And if you look closely, we see that we see two patterns on the same clip. And one of them shows no lung sliding, the other one does. And this is the point of separation of the two pleural leaflets. So basically, when we would use this would be either if we're undergoing a routine scan, but usually where it has a big impact on our management is if we're faced with an unstable baby, we start scanning the anterior chest wall, we see there is no lung sliding, we only have these A lines, then we will move the probe laterally until we find the point of separation of the two pleural leaflets where the pneumothorax actually ends. And when we have these two patterns on the same screen, what we call here the lung point, then we know that this is pneumothorax. No other condition gives this pattern. So pneumothorax is something that can be life-threatening. Pneumothorax is very quick to diagnose using lung ultrasound. And there are no other conditions, if you follow closely and look for this lung point, that will give this pattern. And if you're unsure about whether there is lung sliding or not, there is the possibility to use the M mode on your ultrasound machine. And what it will give you are these parallel lines over here. There is no difference between the upper and the lower part of the screen, what we call the stratosphere sign. Pneumothorax, I mean, lung ultrasound has a much higher diagnostic accuracy than chest x-rays in ruling out pneumothorax. And when it comes to the recommendations that came out, the use of lung ultrasound is essential in certain situations, settings, and namely when the patient is extremely unstable or when the patient is in cardiac arrest. So this is something that is routinely used in critical care, and it's also part of other protocols that we'll get back to. So what the protocol says is that if you don't have lung sliding, if you don't have any B lines, you only have A lines and no other artifacts, you do find this point of separation of the two pleura, then you have confirmed pneumothorax. If you don't, well, then you should normally do an alternative imaging technique, except when faced with an unstable patient or in cardiac arrest. Then it is definitely recommended to use lung ultrasound. And yes, you can treat the patient without making a chest x-ray. It's also essential in limited resource areas where maybe access to other imaging techniques is difficult. These criteria have been validated in the newborn. There was a multi-center study in 2016 by Francesco Raimondi that showed that there was a high sensitivity and specificity to these criteria in the newborn for detection of life-threatening tension pneumothorax. And since then, we've also got to know that diagnostic accuracy is optimal compared to other techniques we have in neonatology. It's quicker than chest x-rays. And there's been case studies showing that lung ultrasound can guide needle aspiration or chest drainage. And then another condition, pleural effusion, which we know we've been using ultrasound for a very long time. Just going back to the evidence here, using lung ultrasound to diagnose effusion is safe. The diagnostic performance is superior to that of chest x-rays, and we can use it for diagnosis and serial follow-up. What we do know is that ultrasound-guided thoracentesis reduces the risk of complications and it increases success rates. I would say there is an enormous potential in neonatology, but until now, we don't really have any specific data. The first, let's say, pediatric-specific guidelines that came out were more a summary of the evidence and let's say the first step, towards training guidelines that that we're waiting for. And as you can see here, and I would really recommend this paper because there's a very nice summary of papers that were published until 2015, 2016. And you can see that for identifying pleural fluids in emergency medicine, pneumothorax and parenchymal pathology, lung ultrasound definitely has its applications. So going back to the NICU, today, I think most of us are using landmarks when we insert needles or drains, tubes into the chest. Most of us have been trained to using the safe triangle, so landmarks. The question is, how safe is it really? Has anybody really looked at that? I mean, I've been lucky to have held a certain number of workshops on lung ultrasounds and on infants, on babies, but also in older children. And sometimes I'm surprised at how high the diaphragm goes. Actually, it's quite scary. So how safe is a safe triangle? Who knows? Maybe if we look closer with lung ultrasound, we can make it even safer. We know that ultrasound-guided procedures reduce complications and also increase success rates. And in all all thoracic societies recommend that whenever we need to stick a needle into a patient's chest, we should be using ultrasound to do that. And in the ESMIC recommendations, the statement is that POCUS is helpful to guide thoracentesis in neonates and children. There's a strong agreement with the quality of evidence be. But are we really using it? Are we really trained to do that? I think many of us are doing, ultrasound guided or non-ultrasound guided drainage. Many of us are using POCUS in different situations, but I think using POCUS protocols could be very interesting. When it comes to radiology, we know that variable operator skills can lead to differences in the imaging. And in radiology, what we see is that when you have protocols, you reduce exam times, you get consistency in image acquisition, and you get better quality, meaning that you can review them or actually base your diagnosis on them. But we're in a different situation. Today, we're talking about the acutely deteriorating patients. Our POCUS protocols or point of care protocols should not interfere with the ongoing management. This is a major point. We should be able to continue our resuscitation measures. Let's say we have a baby that's previously stable, who goes on to deteriorate, either needing resuscitation or needing us to increase oxygen levels, very high levels to maintain stable stats. And we don't know why. We don't have any clinical point that does help us find out what's going on. Using ultrasound here could give us some idea of the underlying pathology, but it should never at any point interfere with ongoing management. We should be able to use our resources efficiently. We have to think about patient safety. It's always a benefit risk. What are the questions I'm asking? Because if I'm just blindly putting the probe, maybe I will not necessarily come to a conclusion that will help me manage this patient. It should be help for me, the operator. And then again, when we're looking at POCUS protocols, we should be able to see whether we can improve outcomes. But then again, which outcomes should we be looking at? Should it be patient survival? Should it be time to diagnosis? Should it be clinician comfort and stress levels? Should it be how we're able to personalize or individualize our management? These are all ongoing questions. I think that we should be inspired by adult medicine. Adults have integrated lung ultrasound into point of care protocols. These are focused algorithms. For example, you can use these algorithms as non-cardiac hemodynamic monitoring in patients who present with respiratory distress. Or you can also use them for specific clinical questions. So, for example, in a trauma situation, you would integrate lung ultrasound to ask whether you have bleeding. And then again, what you really want to do is to add an added value. You want to be able to intervene quickly when you're faced with life-threatening emergencies like tamponade, pneumothorax, and massive effusion. You should not at any point be losing time on this. One of first persons to integrate lung ultrasound into more general protocols is Daniel Lichtenstein. Daniel Lichtenstein is the father of lung ultrasound, and the way he has of really seeing patterns and putting these patterns into algorithms, simple for the clinician, easy to learn, and very logical, I think is a major, let's say, I was almost used the word breakthrough, because it's possible. What we need as clinicians to do is ask a specific question. So the Blue protocol is specifically designed for the patient who presents with respiratory distress cyanosis, so a Blue patient. And it really goes through the basics of a structured lung ultrasound examination. We start off by scanning your anterior chest wall. You will look for lung sliding. If you do not have lung sliding, that's not normal. Then you go through, check if you only have A lines. If you only have A lines and you find the lung point, then you've diagnosed pneumothorax. If you only have A lines, but you don't have the lung point, like I said, you would need to go for other diagnostic modalities. We're not here in the case of an arrested patient. On the other hand, if you do have lung sliding and you have so many B lines, you're in a B profile that is concordant with pulmonary edema, and what you want to do is go and look at do echo or assess your cardiac function and probably start treatment for heart failure. And then again, if you are with lung sliding, but you have a normal lung, an A profile, then what he suggests is that you look at it differently. You will say, maybe really it is not the lung, it's probably hemodynamics. And in adults, well, you should be thinking about pulmonary embolism. So start off by checking your veins or femoral veins or smaller veins. And if you have signs of thrombosed veins, then you should definitely go the next step to rule out a pulmonary embolism. If your veins are free, then you should be looking at the posterior lateral areas to check for effusion or for pneumonia. The FALS protocol is very interesting. This is integrating lung ultrasound, again, simple steps in the case of shock. So you have a patient who presents with undifferentiated shock. The first thing Daniel Lichtenstein suggests you do in the FALS protocol is that you do a very simple focused cardiac examination, basically eyeballing. You're looking at signs whether there is tamponade or right ventricular dilatation. Then you would already have a diagnosis, and then you would start off by looking for pneumothorax on the lung. These would all be causes of obstructive shock that you would want to treat. If you've ruled out obstructive shock, then the next thing is to look if you have a B profile, so concordant with pulmonary edema, then that's most probably cardiogenic shock. If your lung is normal and you still have shock, then it could possibly be hypovolemic shock. And what you suggest is that you start giving fluid administration. If your patient improves, well, bingo, this is what it was. If your patient does not improve enough at any point, then you probably are faced with distributive shock, usually septic shock, and fluid therapy might improve a bit, but probably not all your signs of shock. And a very interesting way of following the patients up is a patient who has, an A profile, and you're giving fluid therapy to improve pressures. When you see the B lines appearing, that means that you will no longer have any benefit of giving fluid. You should probably stop because you are drowning the lungs. And another protocol, again, which I think is interesting for us to see because it's clocked. A protocol has to be really quick. A protocol should not interfere with ongoing management, and especially in the case of cardiac arrest, like the case of the Sesame protocol, which has as an objective to actually find out the underlying etiology, if possible, to be able to treat the cause, like, for example, tension pneumothorax, pulmonary embolism, or hypovolemia tamponade, and so forth. But what about us working with the newborn baby? What about, patients either not responding to normal resuscitation measures in the delivery suite, or even, let's say, in a different setting, like in the NICU, previously stable infants who suddenly and unexplainably go on to deteriorate, often quite quickly, without any other clinical signs to help us manage these patients. I think by really integrating our knowledge in POCUS into focus algorithms that respond to specific clinical questions or contexts, I think that this could be of big benefit to us as clinicians. These protocols should be easy to learn and quick to perform, and again, should not interfere with ongoing management, but on the contrary, give us insights into what's going on, what the underlying physiopathology is. The first such protocol to be published is the SAFER protocol. So SAFER stands for sonographic assessment of life-threatening emergencies. And the R is the second part when it was revised. It's based on the philosophy behind Daniel Lichtenstein's algorithms and other protocols like the FAST protocols for trauma and so forth. The thing is, when you're faced with a crashing patient, you don't have much time. So these protocols, like the SAFE protocol, use one probe, a simplified stepwise approach using a rule in, rule out approach. And the SAFE protocol and the SAFER protocol are based on they are, let's say, based on urgent and the most common complications in the NICU, but the order is in the order of urgency. So, for example, cardiac tamponade is rare, luckily, but it really, really is urgent to treat it. And it's very difficult to make the diagnosis clinically or by using a chest x-ray. So there really is an added value to doing a quick point of care ultrasound examination. Tension pneumothorax, effusion, etc. are also not that common, but still sufficiently common and sufficiently urgent that we really need to get this information quickly. The SAFE protocol needs minimal training to perform and allows for timely management. So what does this say? Say that starting again, a bit like the FALS protocol from Daniel Lichtenstein, you start off by putting your one probe, the one you will choose, on the anterior chest wall or substernally to eyeball your heart, check for myocardial dysfunction. And at all points through that protocol, we need to remember that we are in a period in life where there could be congenital heart disease. And at all points, we always need to keep that diagnosis in mind and call for expert help. These protocols are not meant to rule out congenital heart disease. What they're meant to do is to give us some information on the underlying physiopathology that can help us rule out or in the most urgent complications in the NICU so that we can manage them in a timely way. So start off by checking myocardial dysfunction. If there is gross myocardial dysfunction, we also need to find out why, but then that will give us time to call for help for somebody who can do an echocardiogram. Is there tamponade? This is something that's quite easy to learn. If there are signs of tamponade, yes, then we'll go on a needle aspirate. If not, we'll look for signs of tension pneumothorax and then effusion. So starting off by myocardial dysfunction, what you would need to do is to get a quick idea of how the heart is contracting. You would agree with me, for those of you who are not that used to doing point of care cardiac ultrasound, that here the clip on the left that says V shows a heart that's contracting normally. At least there is no signs of severe dysfunction, whilst the one on the right shows a completely different picture. We don't need a lot of training to see that this heart is not moving that well. So something is wrong here. And if we prefer to use the parasternal axis, this is a heart that is contracting. The problem here is not gross myocardial dysfunction, and whatever is going on is not affecting myocardial contractility as compared to the heart on the right. We all agree that this does not look good. This is a very severely depressed heart for some reason, and in addition, here we can see there is a fusion. So what about tamponade? Tamponade is life-threatening, whatever its cause. And in high volume NICUs, unfortunately, this is something we're faced with at least once or twice a year. Previously stable infant that goes on to have more spells than usual, for example, or just crashes. And for that, you can either use a sub.
Nadia, you'll have to unmute.
Yeah. My apologies, I'm not really sure when I muted. So we can either use the subcostal view or here the transthoracic view. And you can see there is a large amount of volume with a heart that's compromised. Okay. So if there's tamponade, we do something, and we can start to manage the patient quickly. Well, what about when there is, luckily, myocardial function is good, there is no tamponade, then we will start scanning the lungs. And we will move the probe to the anterior chest wall using a vertical scan. The first thing we'll do is to assess for lung sliding. If there is no lung sliding, the next question would be, do I only have A lines, no B lines? Yes. So if I have no other artifacts than the A lines, then move the probe laterally until we reach the lung point, which is the point of separation of the two pleural leaflets, which would then confirm the diagnosis of pneumothorax. If we don't find the lung point, and that could be possible in complete pneumothorax, the diagnosis of pneumothorax is still highly probable. Although, if the patient is sufficiently stable, we could do another diagnostic modality in the very unstable patients, especially when we have a difference between the two sides. We're allowed to needle aspirate or treat as per local protocol quickly. So again, showing you what that would mean that on one side is the anterior chest wall. There is no lung sliding here, only A lines, no B lines. And moving the probe laterally, we come to this point of separation of the two pleural leaflets, sliding and B lines. And the place where we find this lung point is indicative of how large the pneumothorax is. If our lung point is limited to the anterior chest wall, then this is probably not a cause. This is something, it's an incidental finding. However, if the lung point has crossed or is around the middle axillary line, then it's a moderate pneumothorax. Whilst if it has crossed the posterior axillary wall, then this is definitely one of the causes at least, or a cause of compromising the patient. And again, moving the probe laterally, it's really worth the time to confirm diagnosis and to get an idea of how large the pneumothorax is. Tamponade, no. Lung sliding, yes. So very quickly, we have ruled out pneumothorax. There's no need to go for a chest x-ray to think about whether there's pneumothorax or not, or do transamylation for those of you doing this. If you have lung sliding, you have automatically ruled out pneumothorax and you can move on to something else. you're not going to waste more time asking yourself the question, or do the way we did a long time ago when we stuck needles in, because I mean, impossible to rule it out clinically. We didn't have time. So if you see lung sliding, then you've definitely ruled out pneumothorax, and you can move on down your checklist. Is there effusion? So we're working with patients who have long lines, and it's underreported in the literature, but I think you would agree with me. Most of us have been faced with patients who have decompensated because of a huge effusion related to diffusion of parenteral fluid, so perfusothorax. And the SAFE protocol says you then move your probe to the posterior lateral chest wall. What you're looking for is a large effusion. A tiny effusion will not decompensate your patient. So if you confirm your diagnosis, then you will needle aspirate. It would look something like this. It's always important to know where you are to be able to identify your anatomical landmarks: diaphragm, pleura, liver and or spleen, depending where you are, because you want to be sure that this effusion is really in the thorax and not in the abdomen, and using the abdomen as a landmark, I mean the diaphragm as a landmark, is important also. You can have something like this. As you can see, a large effusion with a consolidated lung. So the SAFE protocol is easy to learn. It addresses the most urgent life-threatening emergencies in the NICU, and they are classified by order of urgency again. It's designed for the neonatologist that needs minimal training to perform. And to show you this, this is one of our juniors. She's had, I think, about 2 months of training. She had a short training in the SAFE protocol and in lung ultrasound as a whole, and she's performing the SAFE protocol in a relatively stable baby. And just to show you how much time it takes, the idea is not to do it quickly as possible. The idea is to gain quick information, but also reliable information. So you would need time to perform it correctly to be sure whether you do or do not have lung sliding, to get the best quality image possible in that context, to base your decision making on that. So she's done. She's ruled out the main diagnosis in the intrathoracic part. And then from SAFE to SAFER. SAFER is sonographic assessment of life-threatening emergencies revised, where we wanted to include other extrathoracic complications. Again, always keeping in mind that you always have to rule out congenital heart disease in this age group. And I would really like to thank Virginie Montpetit for her help, both with the SAFE and the SAFER protocol. She's worked a lot on the ideas around this, and hopefully we'll be able to work even further on making this something that could also include other diagnoses. The SAFER protocol says once you've ruled out these, then you would move your probe downwards and assess for signs of critical aortic occlusion. If you have a pulsatile abdominal aorta, then you can rule that out. It doesn't mean that you don't have a congenital heart disease or a coarctation. It means that it is not critical at that time point. And then you move down to the abdomen, the iliac fossa, to assess for abundant free abdominal fluid. If you do find that, then you should do target workup in the abdomen. For example, you should suspect intestinal perforation, extravasation, hemoperitoneum, depending on the context. If not, critical acute abdomen at that time is improbable. And then we would move the probe to the to do a cranial ultrasound to assess for severe IVH. Unfortunately, as we know, there is no curative treatment for that, but the patient could be decompensating, for example, because of massive bleeding, and then we would be able to administer supportive management. If we've ruled out all this, then we would need to, assess for other diagnoses like sepsis, so most probable, or metabolic or endocrine. The SAFER protocol allows us to rule out a number of diagnoses, and then that gives us more time to start other workup or management in other kinds of emergencies that are probably not as common in the NICU setting. It is specifically designed for the patient in the neonatal intensive care unit who's previously stable, and who deteriorates. It is not designed to be used, for example, in a well baby setting, because the reasons behind an acute deterioration in a previously well baby would be completely different. It would be wasting time for that baby to start looking for, acute pneumothorax or a large effusion. This baby probably has congenital heart disease or sepsis or metabolic endocrine. One size does not fit all. These POCUS protocols have to be applied for a specific predefined population setting. And the SAFER is for the NICU baby who decompensates, where we first go out to check the heart to assess for tamponade, the lungs for tension pneumothorax or massive pleural effusion, the aorta for critical aortic occlusion, thrombosis, or critical coarctation, the abdomen, free abdominal fluid, and then the brain for severe IVH. I believe there's an enormous potential if we start to work on protocols like this together. For delivery room emergencies, taking it a step further in our resuscitation protocols, we stop at A, B, C, D, E, right? E for environment. I think we should include the F for focused ultrasounds, finding out why we have difficulty resuscitating infants, why they're not transitioning correctly, why they're not responding, with specific questions. Again, the NICU decompensation, like with the SAFE and SAFER protocols, but also for crashing babies in the maternity ward, well babies who come in. Most of the etiologies that can be found using ultrasound can be put into these algorithms, but we need to think about how to make them as specific as possible. They need to be helping us clinicians to answer specific questions that then we can use to manage our patients. I think also in transport, there is emerging evidence that this is a very useful tool to be able to use even before we start transporting the patients, during retrieval. But in any case, we really need to be working together in multi-center collaboration to find out how we can make this as safe as possible for our patients. And another protocol that has just been published is the CNP protocol, the crashing neonates protocol, which again is a multi-organ POCUS protocol that seeks to help clinicians faced with a non-responsive infant. And the CNP is designed more in a circular view where you can use cranial, lung, cardiac, and abdominal POCUS, and then use it then to guide your management. For example, for lung POCUS, again, you've got the effusions, thoracentesis, large consolidation where you want to adjust your ventilation strategies if you have a ventilated patient, pneumothorax, cardiac, when it comes to tamponade, pericardiocentesis, giving fluids, pulmonary hypertension, or poor contractility, abdomen. So this is circular, and you will come in really depending on the clinical context. But I think this is really just the beginning. I think there is an enormous potential, but I also see that so many barriers remain. We do have an inherent resistance to change, and that is multifactorial. What is true also is that we have significant variation in clinical practice, even within the same countries or areas. But where I'm working, we have poor governance structures, we have poor training structure. We don't have any training guidelines, although I know there is a lot of work and collaboration being done today in order to be able to think about how we can harmonize our practice. I still believe that we don't have enough access to training and mentoring so that everybody can get at least minimal training to feel more confident and to improve a quality of care in these stressful situations. And it's especially, I think, in these stressful situations where we need easy tools we can learn that we've practiced and that we can use to help us guide our management. And again, of course, what about medical legal concerns? We know we have very different legislations in different countries. Today, we have our specific pediatric guidelines. They have been published. But we definitely do need education guidelines and training guidelines. That's urgent. And certification, possibly, but governance for sure. But integrating lung ultrasounds into POCUS protocols, for me, this is really the next step. I think this is where we really take it a step further towards achieving our objective of patient-centered medicine when it comes to, I mean, depending on the context, are a patient in the delivery suite who has difficulties transitioning or is not responding to resuscitation measures here as for the safer protocol in the NICU, the well baby, and so forth. I think asking a specific question, going back, taking a step back and saying, who is my patient? Which protocol should I use here? I really do believe that this is somewhere we should be heading, but there's so much work to be done. And I really do hope we can do this together. I'd like to thank you all for your attention. I'd like to thank the teams at Paris-Saclay University where I work, and I'd be happy to take your questions.
Thank you so much, Nadia, for an absolutely fantastic talk. I think a huge amount of food for thought for everybody in the audience. I'm going to start by just going through the poll that we have. So we had a total of 67 attendees, and we've had 48 of them respond. And basically, it's reasonable. 13% of them are and follow a confident protocol when performing POCUS for the acutely deteriorating neonate. A whopping 50% don't have a protocol. 57% don't have a protocol, and that extra 7% have asked for the evidence. But it's heartening to see that there are people, about 20% of the respondents are using point-of-care ultrasound, and they're using it with or without a protocol. That's progress, I would say. I'm going to start by asking Nadia some of the questions from the messages. And one of the questions that's been asked quite a bit is use of the probe in the safer protocol, because you don't want to change probes. So which probe would you feel is most appropriate?
Well, thank you for that question. It is a very good question. I would say that, I mean, the exact answer is difficult to give. The probe you should use is the one you have, right? There shouldn't be a limitation. Let's say you're working with a machine and you only have a cardiac probe. Use the cardiac probe. However, if you're lucky enough to have several probes, you can choose to use, for example, a linear probe that you use for the lung, because that would be very good also to use on the heart. You're just assessing for tamponade. It would be good for the abdomen. And if the footprint is okay, you will get enough vision of your fontanelle to check for IVH. The microconvex probe, in my opinion, is an excellent probe to use also in the preterm infant. The adults use this. Daniel Lichtenstein advocates this, and it also really works well in the newborn, also for echoes, actually, if you want to go that far. So there has been no study comparing these three probes for the safer protocol. However, there was a study comparing these three probes, so phased array, micro or curved array, and the microlinear probe or hockey stick probe. There really is not much difference for the lung. I think you have to choose a probe that you're comfortable using, the one that works best for you. But each institution should, or each NICU should just decide, maybe even have preset on what you're doing. The idea is not to do a whole, examination of each organ. The idea is to get sufficiently good images so that you can actually see yes or no, and move through. So which probe? If I had access to all, I would either use the microlinear or hockey stick probe or the microconvex probe. I would use the cardiac probe lastly, because it takes some training to really assess the pleural line. And if you're not that used to it, you could be a bit confused. But if it's the only one you have, learn to use it.
That's really helpful. We've got a question from Asma Osman. Can we differentiate pneumothorax from pneumomediastinum?
Oh, thank you, Asma, for that question. You probably can. What you're seeing with pneumothorax, I mean, you would have the same sign in pneumomediastinum, right? Because it is air. However, it would be with the lung point where you have it, the fact that you're moving laterally. And then unless you have a really huge pneumomediastinum, it usually is quite medial. There have been no comparative studies, though. There are really very, very few studies, or I'm not even sure anybody has really published on that. There have been some publications on how you can use indirect signs, like you look at the thymus and then you'd see some bronchograms in there. But for all practical purposes, speaking from experience, I think most of you would agree with me, it is that you have the signs of pneumothorax really medially, and quite quickly you have lung sliding that appears. But then again, maybe we'll find out that's a bit different. But this is what we've seen. I mean, in the years we've been doing lung ultrasound, we often find associated pneumomediastinum.
There's just following that question, there's another one, which is we're getting a lot of portable ultrasound probes these days that you can use with your mobile phones. Do you have any experience of using that and the quality of the images?
I know they're becoming more and more performant. I have not used the ones that you put on your phone, except for one company, but that's quite cheap. The probes are quite big, but I know there are so many machines out there right now. I would really think that many of these machines are quite good, but the most important thing is that you yourself are able to, let's say, interpret the images on the screen, because that's really what we're all going for, is pattern recognition, really, and we have to be able to distinguish that on our machines. What I'm more used to using are smaller ultrasound machines. They are small tablet sized, mini tablet sized. And some of them have really good image quality. The ones that beam directly to your iPhone or iPad, some of them are good, some of them less good. So, but I think that in the coming years, they will be cheaper and more accessible, because people are working more and more on miniaturization and making them wireless and so forth. So the trend is there.
Sorry. There's just one more question. So one of the questions for the safer protocol, just the order in which we're kind of making diagnosis. Is cardiac tamponade more common than pneumothorax? That's why we've gone for that first?
No, absolutely not. Thank you for that question. Cardiac tamponade is luckily not as common as pneumothorax. Pneumothorax is very common. Tension and life-threatening pneumothorax is less common. It's by order of emergency, of urgency, because if you don't drain that tamponade very quickly, you have no time at all. And also the fact that how else are you going to make the diagnosis? Yep. Chest x-rays will not pick that up. And clinically, I mean, how could you pick that up? You really have to have a very, very high index of suspicion to be able to think about the diagnosis. And often we don't, babies have spells all the time, apnea, bradycardia. And if you're not really, really there to think about the diagnosis, you might miss it until the baby is gone into arrest. So it's because it's so time sensitive. You have so little time to act. And we're usually quite stressed when we want to drain pneumothorax. And I mean, the tamponade, I mean, it's very stressful. Yeah. So no, the reason is because it's the most urgent complication.
What a question from Marwa Abdul Karim. Could you explain the lung point in pneumothorax one more time?
Yes, of course, Marwa. Let me try and reshare the screen. So Marwa, I'm not really sure how much experience you have with lung ultrasound. Oops, sorry guys, I have to go through a number of slides here. So bear with me. Here we go. So pneumothorax is the presence of air between the two pleural leaflets. And ultrasound beams cannot go through air. So that gives a very specific picture on lung ultrasound. It's that where there's air between the two pleural leaflets, the ultrasound beams cannot go through. So you cannot see any movement of the pleural line and nothing else but just, repetition of air, which is this horizontal A lines. In a normally, so let's say a lung without pneumothorax, what you do see is this back and forth movement that we call lung sliding, that's synchronous with breathing. The lung point is simply the point of separation of the two pleura, as you can see here with the arrow. And what you do is when you're looking for pneumothorax, you will scan your anterior chest wall, because that's where air goes in a supine patient. And if you then see that you have no lung sliding, you only have A lines, no B lines, and if you're using the M mode, you have the stratosphere sign, then you will start to move your probe laterally, until you start seeing a different pattern. This is the lung point. And on this, it's on this clip is where you have the orange arrow. This is where you have sliding. At the same time, no sliding. This is the lung point. Basically, the lung point is the point of separation, the two pleura, what you see on lung ultrasound in that case. Did I answer your question, Mara?
So does anybody from the audience have a question?
Alok, can I ask you a question?
Yeah, sure. If you could just introduce yourself. Yep.
I'm Prashant, but I'm one of the neonatal consultants at King's College Hospital, London and Dubai. I've just moved in from Brighton. I met Nadia 6 years ago. She's been my mentor too. But one of the problems I found, Nadia, is the buy-in from our colleagues. You see, when I first proposed lung ultrasound, very enthusiastic, right from France, and then you're like, oh, I can do this. It's very useful. It's not been widely accepted, and as you rightly pointed out, I think one of the reasons to address, one of the ways of addressing this could be certification. Do you think that's coming? There's ESPNIC. Do you think that's coming?
Prashant, I agree with you. But I think so moving forward, I don't know what you think, Alok, also. I think that compared to, let's say, 5 years ago, when we used to present things in conferences, or even when we started out with the first large conferences, people were saying, I don't believe in this. But it's, it's not a religion, it's not magic. You don't believe or you don't believe. It's, you look at evidence and you see how that can work. And my impression is, at least that, 5 years ago, maybe 4, maybe 6, around 5 years ago, there's been like a snowball effect. I'm not really sure how. I think maybe we just reached the critical mass, or we're able to show that actually there is scientific evidence for this and that it's changing our management. So there is more interest. However, I do agree with you that the lack of certification, the lack of standardized training is definitely a limitation, a challenge, and the ESMIC is working on certification in POCUS as a whole. I think probably, and Alok also with MPROvE Academy is doing huge work in trying to make this more accessible. Certification is definitely important, but the limitation we have, or let's say the real challenge we're facing, is the absence of mentors. Because most people have told me that, lung ultrasound really is quite easy to learn compared to other kinds of focus. You do need training, you do need experience, but at some point you start to integrate the patterns and it starts to make sense, and then you start to construct this 3D vision in your head, and it starts to make sense in your clinical management. It becomes an extension to your stethoscope. But to be able to get there, you really need, ideally, to be able to ask someone for help, or someone to review your images or discuss together. And this is a big challenge. And I know that Alok is one of those who are trying to find other more creative ways of addressing this. The ESMIC is working on certification, and I think it should soon hear more. And there are also some starting European collaborations on how to try and do this. But I totally agree. Depending on your working, like I would say the UK or typically a context where if you have, let's say, guidelines or recommendations, everybody will help. In France, where I'm working, people like guidelines, not for me, who cares? So there has to be it has to be a perceived added value also. The buy-in also comes from where you see that it will change or it will help you. It doesn't become a hindrance in how you're working. So I think it's multiple. Certification for sure, I do agree, Prashant, and there's work being done on this. I think access to courses and I mean, access meaning really accessibility, that you don't have to travel like very far away, not being able to get feedback once you do your images, I think is a big thing. But above all, I think there has to be this perceived added value. If you feel that it does really help you, and you've seen this, I mean, any of us who've actually diagnosed pneumothorax in a kid who's not okay, you will never go back after that day, right? Or when you don't really understand what's happening and you see it on the screen, or on the other hand, I mean, we've all had experiences. Once you've been there, you never want to go back because you've seen things that you would never ever see elsewhere, and it changes your management. And I think in the future, maybe when we've progressed even more towards our objective of more patient-centered, personalized, individualized care, possibly that might also come in for other, like surfactant administration. So there was a question on BPD, progression towards BPD, ventilation strategies, but I think we have many challenges, and I think that as neonatologists, those of us we're kind of have some inborn resistance to change at some point. I don't know. I'm a bit scared. I don't know about you, but it really, I think it has to do with our culture of saying, yes, it does actually help me. I need help. We often work in very stressful situations. We're on our own. We might, have a feeling of, I don't know, doom when the baby is not getting any better. And this is empowering us. I think if we feel empowered by using the tool, we'll use it. And again, of course, there is governance and politics. If your boss says, no way, you're doing this, you're not going to do it. If your boss says, everybody's going to do this, and we will train that this is patient outcomes or quality improvement, patient safety we're talking about. So I don't know. Does that make sense, Prashant?
Yeah, perfect. Thank you. Yeah.
Just one thing to add to what Nadia is saying is buy-in is also important, because often when you're introducing lung ultrasound into the unit, you will have colleagues who, will not be able to take it up, maybe because they're obviously not so experienced with or don't previously use ultrasound. And working on a guideline that provides them safety in continuing with current practice, whilst also allowing people who are performing lung ultrasound to be able to practice. And a good example is the diagnosis of pneumothorax. Now, it's inevitable that we're going to progress to clinicians in the unit who do and some who don't. And it's giving them the approach of using the clinical or the ultrasound strategy to make that diagnosis, which then gives them the reassurance that actually either practice is acceptable.
Absolutely.
My other kind of approach to the kind of training aspect is, and the mentorship, it's a real challenge, because you do a face-to-face, you go back to your hospital and you might not have anybody to mentor you. And that is a very, very big challenge. The other big challenge is, like, we're running an online kind of a course at the moment. So we have about 35 participants, and really 23 are on way to what we would say is achieving a good degree of confidence in being able to perform lung ultrasound. But it is hugely time consuming, in terms of peer review and mentoring. It is hugely time consuming. And I think you're probably going to have to mix and match and have a group of master trainers in your own hospitals who get the experience and then are able to pass it on. There's one really nice question over here, which differentiating collapse from consolidation, which I always find terribly challenging myself. This is from Asma Osman.
Asma. Okay, I would be a bit stressed to answer the question. The reason is I was trained by Daniel Lichtenstein, and Daniel Lichtenstein is very, very, very strict on using correct terms. So what do you mean by collapsed lung versus consolidation? Because for me, it means exactly the same thing, but I might be wrong. Do you mean atelectasis maybe?
Yeah, I think that's what she means. I
Yeah.
think the difference. Yeah.
Okay. Atelectasis versus consolidation is really tricky. So when we look at most of the literature out there, one trick is to look at the bronchograms, and usually having dynamic bronchograms rules out atelectasis. Having said that, this is what has been published in the adult population, where most of the literature is, and where Daniel Lichtenstein has published most of his papers. In our context, if we're talking about ventilated newborns, it can be more tricky because first of all, we have different degrees of reduced aeration. We're ventilating them, so we might be changing some of the patterns, meaning that if you have an atelectasis, you're opening up, we could still have some dynamic bronchograms. But, and again, another tricky part is what Daniel Lichtenstein calls translobar or consolidation. It looks like atelectasis. But for all practical purposes, I would say that if you have areas with irregular borders, so the shred sign, with bronchograms that are dynamic, then that's most probably a consolidation. And in any case, you need to follow that up. You cannot always in neonatology make the difference just by lung ultrasound. You need to change your ventilation strategy, maybe suction your baby, or, you know, if you have an additional suspicion for, I don't know, pneumonia, you would check that out. Usually atelectasis would look more like a translobar consolidation, meaning that you have larger areas. The shred sign is not always that visible, and your bronchograms usually are not dynamic. But the tidal volumes in infants are so small, so it's not always that easy. So I hope I haven't confused you even more. The difference classically between atelectasis and consolidation is that in consolidation, you have a shred sign and you have dynamic bronchograms. In atelectasis, you don't have dynamic bronchograms. But the truth is kind of in between in clinical practice in neonatology. So you have to use a clinical sense, and you have to use, you know, all the different monitoring parameters and see how that evolves. If you recruit the lung and it opens up, then that was probably atelectasis. If it doesn't, you've got increased accretions, you should probably maybe, you know, like for example, like pneumonia or something like that. BPD, you know, it's kind of a mix. So we have a lot to learn there. I don't think we have all the answers yet. And I'm not really sure we're looking at all the right parameters for that.
I'm going to take the opportunity now to bring the meeting to a close. First of all, thank you so much, Nadia. It's been absolutely amazing, both for the, you know, our group participants as well as for the people who could join us today. So I'm really, really grateful. I'd also like to thank all the participants. You know, some of you from India, you're up at about way past midnight at the moment. So that's,
sorry about that, guys.
I think just, so thank you. And once again, thank you everybody for what has been a fantastic session. I hope you have a good night.
Thank you, everyone. And hopefully we'll meet again online. And if any of you have any questions on the Safer protocols, please just send me a message. We are holding courses regularly on site in France or different parts in Europe. If you are an ESMIC member, or if you are, you know, going to any of the ESMIC conferences, which I'm a member of the POCUS working group and POCUS certification board, we also address the Safer protocol, but we also, you know, give insight in, you know, POCUS, heart, abdomen, and so forth. So if any of you are going to the conference in Athens, would love to see you there. And if not, the launch conference in Milano in October. But feel free to drop me a line. And of course, I mean, thank you again, Alok, for you know, organizing all this and being so dynamic and spreading, you know, lung ultrasound training and courses. Thank you.
Yeah, fruit off the tree, Nadia. Fruit off the tree. You're a big tree. Yeah. God bless you all. Take care. Have a good evening.
Bye bye, everyone. Have a good evening.
Thank you, Alok.
Bye bye.
Thanks. Bye, Alok.
Bye, Dhawal. Bye, Prashant.
Bye bye.